extent of tissue damage or metabolic insult. In the modern perioperative period, this stress response is often detrimental and associated with postoperative morbidity and even mortality. The principal components of the stress response syndrome are two. That is the neuroendocrine response and the cytokine response. The neuroendocrine response is stimulated by painful efferent neural stimuli reaching the CNS, central nervous system, when there is a surgical stimulation or surgical incision or surgical trauma. This neuroendocrine response can be diminished or eliminated by regional anesthesia and high-dose opioid anesthetic technique. The other component of the stress response to surgery is the cytokine response, which is stimulated by local tissue damage and inflammation at the surgical site. The cytokine response is not inhibited by regional anesthesia techniques. The key triggers of surgical stress response are noxious efferent stimuli, pain and anxiety, physiological insults such as hypoxemia, hemorrhage, infection, local inflammatory tissue factors which develop through destruction of tissue, and perioperative factors such as hypothermia. One of the components of the stress response to surgery is the neuroendocrine response. It occurs by four ways. One is the activation of the hypothalamic pituitary adrenal axis. One is the activation of sympathetic nervous system. One is activation of the renin angiotensin aldosterone system and the changes in pancreatic hormone secretions. In the HPA axis activation, there is increased secretion of ACTH, cortisol, growth hormone, and antidiuretic hormone, which come from both from hypothalamus and the pituitary glands. In the activation of the sympathetic nervous system, there is increased circulating catecholamines such as adrenaline and noradrenaline. Renin angiotensin aldosterone system, when activated, it leads to sodium and water retention. And the changes in pancreatic hormone is the glucose secretion is increased while insulin and testosterone secretions are decreased. Going into each of the activated mechanisms through which the neuroendocrine response is activated. The HPA axis and cortisol is due to efferent pain signals which stimulate the hypothalamus, which leads to a cascade of hormone release from the pituitary and the adrenal glands. Serum cortisol concentrations usually peak around 4 to 6 hours from the start of surgery. It usually occurs in the postoperative period. Cortisol and other glucocorticoids are key drivers of the catabolic state. If there is a prolonged neuroendocrine response due to surgery or any other factors, there is a huge catabolic state in the patient, which leads to weight loss and other factors, which is detrimental to the patient. Basically, the cortisol promotes proteolysis. There is a protein breakdown from the muscles and gluconeogenesis in the liver. Cortisol also functions as a cellular and humoral immunosuppressant. The sympathetic nervous system activation and catecholamine secretion is due to the surgical stress and postoperative pain, which results in increased catecholamine release from the adrenal medulla and the sympathetic nerve endings. The key cardiovascular effects of the sympathetic nervous system activation include increased heart rate, cardiac output, systemic vascular resistance, and blood pressure. Metabolically, catecholamines stimulate basically glycogenolysis, gluconeogenesis, and lipolysis, which leads to hyperglycemia. This hyperglycemia is also caused by a decrease in insulin release and also increase in glucagon secretion. The renin angiotensin aldosterone system activation and the antidiuretic hormone secretion from posterior pituitary is increased. Anterior diuretic hormone basically promotes water retention by the kidneys. Antidiuretic hormone also contributes to a hypercoagulable state by increasing the platelet adhesiveness, which leads to a prothrombotic state after surgery or during surgery. The renin-angiotensin aldosterone system activation leads to increased aldosterone, causing sodium and water retention and potassium excretion, which leads to hypernatremia, hypervolemia, and hypokalemia. These effects are actually protective mechanisms to maintain intravascular volume, but it can be detrimental postoperatively, which may lead to edema. The changes in pancreatic hormone secretion, such as glucagon and insulin, is basically due to the stress response to surgery, creating a hormonal imbalance, leading to hyperglycemia and catabolism. Glucagon secretion is increased, leading to hepatic gluconeogenesis and protein breakdown. The decreased insulin secretion leads to peripheral tissues developing insulin resistance, and it also leads to reduced glucose uptake by muscle, fat, and liver. The net effect is hyperglycemia and proteolysis. Going to the other component of the stress response to surgery, the cytokine response, it is initiated by local tissue destruction at the surgical site. Here, inflammatory mediators and cytokines are released even from denervated limbs, indicating a non-neural stimulus. This indicates that regional anesthesia is unable to attenuate cytokine response. The key mediators in cytokine response include interleukin 1 beta, interleukin 6, interleukin 8, TNF alpha. These cytokines basically amplify the hypothalamic pituitary adrenal axis response and contribute to local inflammation and pain. The magnitude of cytokine release is diminished by minimally invasive surgical techniques, not by regional anesthesia or high-dose opioid anesthetic techniques. The consequences of cytokine release is basically 4 effects. One is pyrexia, that is due to the interleukin 1, which acts on the hypothalamus to increase the thermoregulatory set point, causing fever. This fever leads to increased metabolic rate, placing a higher demand on cardiovascular system, especially causing tachycardia. The hematological changes are basically increased neutrophil count and decreased lymphocyte ratio, leading to increased neutrophil leukocyte ratio, or NLR. The platelet adhesion and activated coagulation pathways is through the cytokine release as well as through antidiuretic hormone release from the posterior pituitary, which leads to a prothrombotic state. The metabolic consequences of stress response to surgery during in carbohydrate metabolism is hyperglycemia, which may lead to myocardial ischemia infarction, renal failure, and wound infection. Protein metabolism, there is chances of proteolysis, which leads to lean muscle mass loss, up to 0.5 kg per day of loss from the muscle of the patient, which ultimately leads to weight loss, muscle weakness, and delayed recovery from surgery. The metabolic consequences in fat metabolism is lipolysis, which leads to increased free fatty acids, and which ultimately leads to increased ketone bodies in the body, which is an alternate energy source. The cardiovascular effects of systemic stress response to surgery is through the systemic sympathetic nervous system stimulation activation, which increases myocardial oxygen demand by increasing the heart rate, blood pressure, systemic vascular resistance, and contractility. It also causes coronary artery vasoconstriction, reducing myocardial oxygen supply, in turn, which may lead to myocardial ischemia and infarction due to myocardial oxygen supply and demand imbalance. Patients with history of ischemic heart disease may lead to myocardial ischemia and infarction. Postoperative hypercoagulous state due to ADH-mediated increased platelet adhesiveness as well as the cytokine response leads to increase in thrombotic risk. The effect of stress response to surgery on the respiratory system leads to pulmonary dysfunction. It is also contributed by postoperative pain. The most significant change is a reduction in functional residual capacity. Pain limits deep breathing, especially after thoracic and abdominal surgery, which leads to a smaller end expiratory lung volume. When functional residual capacity falls below the closing capacity, there is closure and collapse of the small airways during normal expiration, which results in atelectasis, ventilation perfusion mismatch, shunting, and hypoxemia. The effects of stress response to surgery on the gastrointestinal tract is basically postoperative ileus. The stress response creates an imbalance between the sympathetic and the parasympathetic nervous system with relative sympathetic overactivity. This efferent sympathetic output combined with efferent nociceptive input, especially during abdominal surgery, impairs GI motility. The clinical result is postoperative ileus. It delays the resumption of enteral diet, and the resulting starvation can itself prolong and exacerbate the stress response to surgery. The effects of SRS on the renal system is due to activation of the renin-angiotensin-aldosterone system and increased secretion of ADH. These hormonal changes cause the kidneys to retain both salt and water. Also, potassium excretion is increased, which can lead to hypokalemia. This state of salt and water retention can persist up to 5 days postoperative period. The inflammatory response and potential renal hypoperfusion also increases the risk of postoperative acute kidney injury. Regional anesthesia involves basically targeted nerve blockade to interrupt pain and stress signals. It includes neuroaxial and peripheral nerve blocks. In the neuroaxial type of regional anesthesia, we can do spinal anesthesia, epidural anesthesia, and combined spinal epidural anesthesia. Regional anesthesia differs from general anesthesia by preserving consciousness and reducing system effects. Regional anesthesia modulates stress response by blocking efferent nociceptive pathways. It is applicable almost to all types of surgeries right now, especially orthopedic, abdominal, cardiothoracic, and limb surgeries. How regional anesthesia modulates neuroendocrine response? It blocks efferent signals to hypothalamus, thus reducing cortisol and ACTH release. It also attenuates pituitary hormone surges like growth hormone and vasopressin or ADH. It prevents insulin resistance and hyperglycemia more effectively than general anesthesia, as evidence from trials shows lower stress hormones in regional anesthesia groups. The benefits are more pronounced in lower body and pelvic surgeries, in which type of surgeries we produce or we give regional anesthesia. The regional anesthesia's impact on sympathetic activation, sympathetic nervous system activation, is basically inhibiting the sympathetic outflow, thus stabilizing heart rate and blood pressure. It also reduces catecholamine levels, as examples of adrenaline and noradrenaline, during and after surgery. It improves myocardial oxygen balance in cardiac risk patients by stabilizing heart rate and blood pressure, and thus minimizing myocardial oxygen demand and supply imbalance. Especially for upper body procedures such as thoracic surgery, thoracic epidural techniques are very effective in reducing sympathetic nervous system activation. Compared to GA alone, regional anesthesia has fewer hemodynamic fluctuations if administered carefully and correctly. If we see a comparison between regional anesthesia and general anesthesia, regional anesthesia more effectively blocks stress pathways than general anesthesia alone. Combined general anesthesia and regional anesthesia reduces cortisol and catecholamines up to 24 hours in the postoperative period. Regional anesthesia alone shows superior suppression of metabolic changes. General anesthesia often exacerbates sympathetic and inflammatory responses if administered alone. Evidence favors regional anesthesia for stress reduction in multiple surgical types, as evidenced by multiple publications. Regional anesthesia has its clinical benefits in postoperative pain management. It significantly reduces postoperative pain scores and also decreases opioid needs when the world is moving towards lower opioid consumption. Regional anesthesia provides targeted analgesia without systemic side effects. It also gives a benefit of lower incidence of chronic postoperative pain or CPSP, chronic post-surgical pain. It also improves patient satisfaction and early mobilization, especially after thoracic and abdominal surgery, if correct type of regional anesthesia is given. Regional anesthesia is supported by random RCTs and meta-analysis in orthopedic procedures and other major surgeries also. The further benefits of regional anesthesia is cardiovascular system stability. Regional anesthesia enhances hemodynamic control, thus reducing myocardial stress. It also decreases incidence of perioperative cardiac events. It is beneficial, especially in elderly and comorbid patients. Epidural techniques lower myocardial oxygen consumption and is also associated with fewer arrhythmias and hypertensive episodes. If you look at the benefits in the respiratory system, regional anesthesia reduces pulmonary complications such as atelectasis and pneumonia. It also leads to early mobilization of the patient. Regional anesthesia preserves immune response, lowering infection rates. It causes earlier return of gut function and reduced postoperative nausea, vomiting. It decreases SSTI and ICU admissions. Overall mortality reduction is seen in select high-risk cohorts. In high-risk populations, regional anesthesia leads to shows improved outcomes in elderly patients due to stress attenuation. In cardiac patients, there is a reduced catecholamine surges leading to reduced incidence of perioperative myocardial ischemia or infarction or arrhythmias or any other cardiovascular complications. In oncologic surgeries, there is a proposed paper actually. There is lower cancer recurrence risk if regional anesthesia is provided during the surgery. In obese or respiratory compromised individuals, they have experienced fewer complications from regional anesthesia rather than general anesthesia. Evidence from observation studies and trials support prioritization of regional anesthesia over general anesthesia. The types of regional anesthesia techniques are two types. One is neuroaxial and the peripheral nerve blockades. Spinal anesthesia blocks lower body stress responses effectively. The only problem with spinal anesthesia is that it can be given a single shot. Nowadays, we can do intrathecal prolonged spinal anesthesia or intrathecal prolonged blockade, or we can give an infusion of intrathecal regional anesthesia blockade. Epidural provides wide-ranging analgesia for abdominal surgeries. Combined spinal epidural is ideal for prolonged procedures, and thoracic epidural, especially during cardiac surgery, suppresses cardiopulmonary bypass-related catecholamine surges. The basic benefits of regional anesthesia techniques, especially neuroaxial regional anesthesia techniques, include reduced hyperglycemia and endocrine activation due to attenuation of stress response to surgery. Peripheral nerve blockade regional anesthesia techniques. If we provide interscalene blocks for shoulder surgery, it's seen that it reduces systemic stress. Femoral and sciatic blocks modulate orthopedic stress responses. Ultrasound-guided approaches, which is the gold standard right now, the ultrasound-guided approaches improve precision and efficacy and lower complication rates. Continuous catheters extend stress modulation postoperatively. Lower opioid, there is incidence of benefit of lower opioid uses and better mobility in extremity surgeries. If you do a comparison of continuous and single dose regional anesthesia techniques, continuous infusions provide sustained stress response attenuation. Single dose effective for short procedures but limited duration, as there may be stress response to surgery in the postoperative period once the block wears off. Catheters reduce long-term cytokine elevation if you can keep the catheters for up to 48 to 72 hours. Continuous infusions are preferred for major surgeries to prolong the benefits, and evidence shows better outcomes with continuous methods of regional anesthesia. How to optimize regional anesthesia? Ultrasound is one of the techniques. Ultrasound improves nerve localization and reduces complications. It also enhances block success rates in challenging anatomies. It allows real-time visualization for precise dosing. It also reduces vascular puncture and nerve injury risks. And it is essential for international standards in regional anesthesia practice. The other method of optimizing regional anesthesia is use of adjuncts and using a multimodal strategy. Adjuncts like dexmedetomidine prolong block duration. Multimodal analgesia combines regional anesthesia with non-opioids. Regional anesthesia is integrated in the enhanced recovery after surgery for comprehensive stress reduction. It reduces overall anesthetic requirements and side effects. And it also improves patient-centered outcomes like early discharge, which is a component of the ERAS protocol. Regional anesthesia in ERAS protocols. Regional anesthesia is central to ERAS for minimizing stress and accelerating recovery. Due to reduced gut dysfunction, and which promotes early feeding, which is one of the major requirements for ERAS protocol. It also lowers complication rates in colorectal and orthopedic ERAS. It supports opioid sparing strategies in protocol design, and regional anesthesia evidence from ERAS societies endorse regional anesthesia integration into the ERAS protocols. The challenges in regional anesthesia effectiveness is due to many factors there are. One of them is the technical failures due to the anatomical variations or operator experience. There is a limited access in resource constraint settings like those of us, like low to medium income countries. There is a potential for hypertension with neuraxial techniques. There is patient-specific factors like obesity, which may complicate block placement. And there is a need for specialized training and also equipment. We are all aware of the contraindications and complications of regional anesthesia. Absolute contraindications are infection at site or coagulopathy. Related risks are hypotension, nerve injury, or local anesthesia toxicity. Monitoring is essential to mitigate cardiovascular effects such as hypertension or arrhythmias or any other cardiovascular effects. Rare but serious, one of the complications of epidural anesthesia is epidural hematoma or epidural abscess. And patient education key to inform consent. Patient education is a key to inform consent in case of regional anesthesia. If you look for regional anesthesia in orthopedic surgery, it is preferred for joint replacements, especially to reduce stress and postoperative pain management. It lowers blood loss and transfusion needs. It allows early mobilization and functional recovery. Evidence shows reduced CPSP or chronic pain post-arthroplasty. And if you use ultrasound-guided blocks, it enhances precision in limb surgery. If you use regional anesthesia in abdominal and pelvic surgery, we can use epidural regional anesthesia. It leads to attenuation of stress in major abdominal procedures and almost all major abdominal procedures. It reduces chances of ileus and promotes gut motility, so we can give enteral feedings early. It lowers inflammatory markers and lowers risk of sepsis due to decreased neuroendocrine and cytokine response. It is beneficial in high-risk patients for hemodynamic stability and is supported by trials, especially in aortic and colorectal surgeries. In thoracic and cardiac surgery, the use of thoracic epidural reduces cardiopulmonary bypass-induced catecholamine surges. It leads to improved pulmonary function and reduces also ventilation needs. It lowers cardiac events such as MACE risk in comorbid patients. Peripheral blocks are needed for minimally invasive procedures, and evidence from cardiac trials show decreased stress hormone. The role of the anesthesiologist in regional anesthesia management is in all the phases of the operative management, that is the preoperative assessment to optimize patient selection, the correct patient, the correct type of regional anesthesia, the intraoperative monitoring for hemodynamic stability or instability, the postoperative follow-up for block efficacy and if there is any complications or not, and education and training for multidisciplinary teams. And an anesthetist usually has to advocate, one who practices regional anesthesia has to advocate for regional anesthesia, especially in ERAS and stress reduction protocols. What are the strategies to make regional anesthesia more effective? We can use standardize ultrasound use for all peripheral blocks. We can combine adjuvants to extend duration. We can integrate real-time monitoring tools. We can train on continuous catheter techniques, and we can put a audit protocol or audit outcome to redefine or refine protocols. We can also make regional anesthesia more effective to multimodal strategy. We can pair regional anesthesia with NSAIDs and acetaminophen for synergy. We can incorporate regional anesthesia into opioid sparing regimens. We can use in conjunction with patient education programs, and we must align with ERAS for holistic care. We must also monitor for additive benefits in stress reduction. In high-risk patients, to make regional anesthesia more effective, we must tailor the regional anesthesia local anesthetic doses for elderly patients to minimize hypotension. We can use low volume techniques in obese patients. We will have to preoperatively optimize the patient, preoperatively optimize his comorbidities. We can also monitor the postoperative infusion of local anesthetics during regional analgesia or anesthesia. We can use evidence-based adjustments for cardiac patients. What are the emerging technologies in regional anesthesia? There is handheld ultrasound devices, which are very common nowadays for resource-limited settings. The upcoming one is the artificial intelligence-assisted nerve localization tools, the novel adjuvants for prolonged analgesia, wearable monitors for postoperative block assessment, and there is a potential for telemedicine in regional anesthesia training. What are the future research directions in regional anesthesia? We must focus on long-term outcomes like cancer recurrence. There need to be more RCTs and meta-analysis. Studies in low to medium income countries for accessibility and cost effectiveness, so that we can increase the amount of regional anesthesia we are providing to patients. We can also explore adjunct combinations for maximal stress attenuation. We can do a longitudinal study on immune preservation by regional anesthesia on the stress response to surgery. We can also see the impact of regional anesthesia on cognitive outcomes after surgery. The barriers to regional anesthesia adoption internationally is the equipment cost and availability in low to medium income countries. There are training gaps for ultrasound and advanced techniques. There is a cultural or institutional preference for general anesthesia. There are regulatory hurdles in resource-limited areas, and there is a need for global guidelines adaptation on regional anesthesia. What is the BASRA's role in overcoming barriers? BASRA is regularly arranging webinars on a monthly basis for perioperative regional anesthesia techniques. They are trying to promote affordable ultrasound alternatives. They are advocating for regional anesthesia in national protocols. And I hope they will collaborate on research for local evidence. To summarize my talk on the stress response to surgery, how regional anesthesia can be more effective. Regional anesthesia is superior to general anesthesia in stress hormone suppression. It is optimizable through techniques and multimodal strategies. There has to be a prioritization of ultrasound and continuous methods in practice of regional anesthesia. It can be integrated, or it has to be integrated into the ERAS protocol and opioid sparing care. And we have to monitor and audit for continuous improvement. Thank you, Basra, for hosting this CME. Thank you. Assalamu alaikum.
Thank you, Riaz. Thank you for the wonderful insight on stress response.
Thank you, Dr. Riaz.
Yes, thank you for the wonderful insight on the stress response, its physiology, pathology, know-how, and how to prevent it, and how regional anesthesia can be more effective in reducing the stress response. Whenever I heard the term stress response, I go back to my FCPS exam, where for the first time in the total training, in the when we are giving the written examination, the question was, what are the stress response in surgery? So everybody was stunned and everybody was like looking at each other, what is this? We don't know anything about it. So that's life, but that is the most important thing now that we know about it. And thank you, Riaz, for explaining it beautifully. And I will request Riaz, তোমার এটা screen share টা বন্ধ করে দাও. I'll request Professor Iqbal is here to shed light on this stress response, because I know this is one of his favorite subjects. Iqbal sir, please.
কি অডিও শোনা যাচ্ছে? ভিডিও নেই?
অডিও শোনা যাচ্ছে স্যার।
আচ্ছা, that's all right then. Okay, আমার প্রথম বক্তব্য হচ্ছে যে this is my favorite subject, as Lutul Aziz has said. Quite favorite actually. আমি এই নিয়ে অনেক কাজ করেছি. In fact, we started with our junior colleague, our colleague, Dr. Shahara Khatun. আমরা তখন আমাদের হাতে তো লিমিটেশনস ছিল, so we wanted to see how the hyperglycemic response to stress, এটা নিয়ে কাজ করেছিলাম আমরা তখন, এবং along with clinical manifestation. তো আমাদের 48 hours এর পিরিয়ড ছিল পোস্ট অপারেটিভ ফলো আপ। তো that came out as a paper later on. আরো কিছু কাজ হয়েছিল পরবর্তীকালে, এখন আর স্মরণ করতে পারছি না, but then we did some other work as well, stress hormones, especially with some cytokines. তো আমার মনে হয় যে ডাক্তার রিয়াজ যে প্রেজেন্টেশনটা দিয়েছে সেটা মোটামুটি ভাবে ওয়েল অর্গানাইজড। স্লাইড গুলো যেমন সাজিয়েছে সে, তো সেই স্লাইড গুলো দেখে পড়ে যেতে তার কোনো অসুবিধা হয়নি। এবং দেন কতগুলো কথা সে মেনশন করেছে, which is right, that by modulating or trying to modify the responses of the stress রেসপন্সটাকে যে এগুলো আছে সেগুলোকে মডিফাই করার জন্য রিজিওনাল অ্যানেস্থেসিয়া ইজ বেটার দ্যান জিএ। অফকোর্স জিএ ইফ ইউজড ওপিয়েটস তাতে কিছু কিছু উপকার হয়, আমার জানা আছে। মরফিন ইজ probably by far the best. Regional with morphine, probably it is a better bargain. As he has already mentioned, that it works better on lower abdominal surgeries and lower extremities rather than the upper ones. Thoracic surgery তে অত বেশি ভালো হয় না সাধারণত। Cytokines, unfortunately, is not been cannot be attenuated because it is a tissue injury. সেই জন্য যে আমাদের আজকালকার দিনের ট্রেন্ডটা হচ্ছে যে মিনিমাল ইনভেসিভ সার্জারিটা বেশি গ্রহণ করা, তা যাতে করে টিস্যু ইনজুরি কম হয়। টিস্যু ইনজুরির এর পাথওয়ে তো আপনাদের সবার জানা আছে যে দিস ইজ an immunological response because of tissue injury itself coming out from the leukocytes mainly, fibroblasts included, and other non immune cells like well, fibroblast is one of them, maybe some other, I don't remember now. It's a macrophage, the local luteal. সেটাই বেশি অ্যাক্টিভিটি তার সাইটোকাইনস গুলো বের করার। IL-6 itself কিন্তু তার একটা রোল আছে যে it itself cause acute phase reaction. তো acute phase reaction সম্বন্ধে ও কিছু বলেনি। acute phase reaction অথবা acute phase proteins প্রোটিনও কিন্তু বের হয়, CRP, ডি ডাইমার এগুলো বের হয়, এগুলো মেনশন করেনি। কিন্তু যা হোক, nevertheless it was it is there. because acute phase reaction এর সঙ্গে জড়িত আছে ফিভার, গ্রানুলোসাইটোসিস, তারপরে acute phase proteins, তার মধ্যে ফিব্রোজেন, আলফা ম্যাক্রোগ্লোবুলিন, এগুলো সমস্ত কিন্তু ইনক্লুডেড। এটা একটা ইম্পর্টেন্ট পার্ট হি হ্যাজ নট মেনশনড, but probably it is not that important as compared to the other ones, especially the catecholamines and the hyperglycemic response, এগুলো ইম্পর্টেন্ট। হাইপোগ্লাইসেমিক রেসপন্স বলেছে যে ইনসুলিন রেজিস্ট্যান্সের কথাটা বলেছে, কিন্তু খেয়াল করতে পারছি না। ইনসুলিন রেজিস্ট্যান্স ইজ অ্যান ইম্পর্টেন্ট ফ্যাক্টর, এবং দ্যাট ইজ, এটার একটা কম্বাইন্ড এফেক্ট আছে। গ্রোথ হরমোন ইজ ওয়ান অফ দেম প্রবাবলি। সেটাও মেনশন করেছে বোধহয়। গ্রোথ হরমোনের কথা বলেছে কিনা আমি খেয়াল করতে পারছি না, মেবি হি হ্যাজ। However, he has done a good job, কিন্তু একটা সমালোচনা না করলে খারাপ দেখাবে, সেটা হচ্ছে যে this presentation is good for us to know, but if you are going to put this particular presentation in a bigger crowd, এখানে কিন্তু crowd is quite big actually, 49 of them. কিন্তু আমি বলছি যে আরেকটু বেটার যদি আপনি করতে চান তাহলে you want to put some references. You mentioned few, অনেক স্টাডি আছে, কিন্তু সেই স্টাডিগুলোর রেফারেন্সগুলোর সঙ্গে সঙ্গে তলায় you had the opportunity to write it down at the bottom of your slides. সেগুলো একটু খেয়াল করবেন, কারণ তাহলে এটা সম্পূর্ণতা লাভ করবে। Without that, it will remain somewhat incomplete. However, I liked your slides. I like your presentation. You are quite you had the flow. You didn't stammer or anything. I think you have done very well. And mostly it is the organizers who have brought 49 of us together to listen to a very important topic, and I'm sure he is going to do some more. He means Luthulajis is the Kornodhar, that he's the guy who is leading them all. So Luthulajis will try to get some more out of the boys if they want to learn good presentation and internationally, not only locally and also internationally. Lastly, I say that everything has gone very smoothly, and probably there will be some questions and which Riaz is ready to answer. Thank you very much, Riaz, and Tulajis and your team.
Thank you, sir. Thank you for your comments and encouragement.
Lutful, I think there are two
Azhar.
Iranian names I can see. Parvana Zadeh and something Popak Rahimzadeh.
Oh, Popak is here.
Yes.
Popak, are you here?
Hello, hi.
Hi.
Yes, I'm here.
You just entered, or you are here from the beginning?
No, sorry, I just missed the time, so I just joined a meeting a couple minutes ago. Sorry for my, I did a mistake in time adjustment.
Okay, I should give Popak's some introduction. She's the senior most anesthesiologist in Iran, working in Tehran University, and she is with me in AOSRA PM, one of the AOSRA PM directors, and we work together. And there's one more name, yes, I couldn't.
Parvane.
Parvane Zandi. Are you here? And okay, I don't know. Are there any comments from your side?
Now, the only issue is that we need to discuss these things with our surgical colleagues. The presentation should include our surgical colleagues in future discussion, especially this topic was very suitable to be presented in a bigger forum. I would request the speaker to organize in their locality surgical colleagues together so that everybody, because there is big denial from our surgical colleagues regarding benefits of central blockers and regional anesthesia blockers, and the combination of regional anesthesia with GA. Even day before yesterday, we had a what do you call unusual situation when our surgical colleague denied to accept benefits to be given to the patient. Anyway, it's a slow process, so we need to win their heart and go ahead. Thank you.
Absolutely. We are trying very hard and we have achieved something already, so we'll achieve more, inshallah. So I have a question from Wahid. Wahid from England, no, Wales. Wahid, will you, can I have some of your comment and your practices in England?
Thank you, sir. Thank you to the speaker for the nice presentation. And this reminds me of my presentation, which I did on 2022 on ERAS in the departmental platform. I think, yes, the emphasis on reducing the stress response in the perioperative arena has been emphasized nowadays, and it's with the advent of regional blocks in conjunction with the spinal and epidural, it's more evident now that patients do benefit from regional anesthesia and regional blocks because the science is clearly there that if you cut off the nociception ahead of the surgical stimuli, it definitely alters the hormonal response, all the immunological responses that to come after the once this incision is done. So I think this presentation would be more appreciable if there were some numbers presented, because everyone likes number. If you want to convince your surgeon or your audience or even the management to why you want to go ahead with regional anesthetic in terms of blocking stress response and what the benefits are. So you need to present the numbers. Are there good evidence? Are there good numbers? Are there good studies? I think just to put some numbers on the slides would make it more clear. And in terms of the practices in Wales, I think we for one of the differences, like for if I take a simple example for cesarean section in North Wales, we put diamorphine in the spinal anesthetic. So with 0.5% bupivacaine heavy 2.5 ml and 300 mics of diamorphine added to the spinal, and it gives a very good pain relief to the patient. That's one of the examples. And orthopedic and trauma is another section where I think widely practiced the regional anesthetic, which particularly in the day case and trauma orthopedic patients, where they put much emphasis to put the patient on the table, do the surgery in the right time, and put blocks like fascia iliacal block, or in case of it can be a continuous block with a catheter in hip fracture patients. Yeah, that's my experience from Wales so far.
Thank you, Wahid. So in there, the surgeons are more accustomed or eager to take regional anesthesia or peripheral nerve blocks during surgery, as we are trying very hard here to make the surgeon understand all these things.
I think, sir, it's same here as well. Like in some breast surgery lists, we had to convince our surgical colleague to whether they would allow us to do the PEG blocks. Some allow, and some of them go with the local anesthetic. So I would say it's not a very different picture here. It's we have to struggle here to convince them that they should let us do the blocks. And so it as a department, everyone comes forward and pursue the surgeons to do that by showing the evidences. Yeah. So, and as in the acute trauma practice, there's also a practice of not putting spinal in many of the patients, which we do under spinal in Bangladesh. They do it with general anesthetic because of sometimes patient refusal, sometimes due to the I would say more of like they're not very familiar with or not very what should I say, not very accustomed or not very comfortable with putting spinal in every elderly patients. So sometimes they go with the general anesthetic for like hip fractures, which are like unthinkable in our country. But here, like the patients say do matter. So if the patient refuses, we have to go for general anesthetic. But again, I think it's noticed, and you know that if you look at the grand picture, the ultimate morbidity and mortality in terms of general anesthetic and regional anesthetic, there's not much difference. So that's one thing they would say to the patient, that yeah, if you could look at the grand picture, there is no difference in mortality or morbidity in general anesthetic or regional anesthetic. So which one would you like to choose? And some patient would then say, I would go for general anesthetic. I would rather prefer to be asleep, not having a needle in my back. That's the thing.
Yes, I have read these articles
Yes,
on the difference, or as you said, the general
grand
anesthesia
picture.
and
Yeah.
general anesthesia, there's not such a difference. But I really don't understand how is this possible on a geriatric patient, 80 plus years old, with so many comorbidities? How come a general anesthesia be similar to regional anesthesia? So
yeah, so
I have doubts about this, all these results.
Thank you, sir.
Thank you. Popak, what about in your country, in Iran?
Okay. Thank you, Dr. Lutful, for asking me. This is a general concern, actually, because this always there is a struggle between anesthetists and surgeons. You should convince them as an anesthetist to perform the regional for the patient. If they agree, yeah, you can proceed with that. But if don't agree, uh, yeah, you should convince the surgeon and both the patient. Sometimes because of the background of the background in the mind that the patient has, because of the history that has been taken from the surgeon, and surgeon is not happy with doing the regional, the patient is not ready for that. When you try to start conversation, stop at the beginning and say, no, please do not proceed with this procedure with me and do the general anesthesia for me. So providing more information, sometimes we are successful in convincing the patient and encourage them to proceed with the regional, but it's not always successful. But it's need really more giving more information to the patient, and also providing more information for the surgeons. And if a surgeon see that your regional works very good, and sometimes they are flexible and they continue this relationship and this this kind of interaction between you and the surgeon, and let you do the regional. But this is mostly with the newer surgeons, with the new generation of surgeons. This most happen with them, that they are more familiar with this kind of regional ultrasound guided regional anesthesia, and they see the difference in their patient. They are happier to proceed with that. But the old surgeons, we have still the barriers with them.
Yes, absolutely true. Absolutely true. It is also true for the anesthesia people, because the older generation still prefers general anesthesia and the younger generation are more into the regional. So younger generation of surgeons are also are taking some interest in regional anesthesia too. Yes, and as Dr. Azhar rightfully said, all these programs we should include surgeons, because they should know whatever we are talking about all these things, the ERAS protocol, the stress response, the importance of regionals, the importance of peripheral nerve blocks in different surgeries. I think it's a challenge for us, and hopefully we are right in our goal, and we will achieve it, and we have done it. And the regional anesthesia is getting popular in every country of the world, so hopefully it will be similar here also. So any other comments, any other questions from anyone, please, you are most welcome. Orin, what is the situation in BMU?
Sir, in BMU, not all surgeons are same. I should say some surgeons appreciate when we offer them to do regional anesthesia for reducing stress response as well as postoperative pain management. But same situation is here, like the abroad, that some surgeons say that you already taken most of the time, or already taken much time, so please do GA. Choose the second case. You prepare for the second case, the first case, please go for GA.
Absolutely.
So I told them, because I work in university, I have the I can tell them that this is a university. So here I have trainees I mean, they need to learn the standard care, standard patient care. So I can do here. Then surgeons allow me, but in private practice, it's very difficult, or government sector. So I should say not all are same. Some surgeons, they
Yes, true. Now
pursue.
that the
Yeah.
BAMU has a separate regional anesthesia division, I think you have more chance of increasing your practice and increasing the regional anesthesia in your patients, hopefully.
Yes, sir. Yes, sir. Now I have you have the division, so we go with team, sir, acute pain team, and then they don't talk much. Like now, please.
Yes.
They just agree with us, sir. Yes, sir.
True, true. Any other comments? Anywhere in Bangladesh, what is the situation, and any comments?
Assalamu alaikum, sir. Can I make a question for Wahid Bhai?
Sure.
Hello, Wahid Bhai. I
Yeah,
hope you're
Rafsan.
listening. And thank you, Haya. Can you tell me a little bit details about your patients when you have total knee replacement kind of patients? You are giving general anesthesia or spinal anesthesia for patient demand. What is your practice for postoperative anesthesia?
So, yeah, we have a rigid protocol for total knee replacement here. The main difference from our department, our department, I would say, the Evercare department, and the practice in Wales is like in here they would do a plain spinal, single shot, plain spinal, no epidural, and would do adductor canal block, same like that we used to do in Evercare. We do a adductor canal block here, and the practice is like for the postoperative analgesia. If you're talking, we got a regime of postoperative analgesia, which basically emphasize on previously they used to prescribe long-acting opioids. So they have stopped prescribing long-acting opioids in the postoperative patients. So if you start from preoperative phase, oral paracetamol, and if there is no contraindication, oral ibuprofen, and in the theater, then spinal single shot without any opioid, along with adductor canal block, and in the postoperative period, they would have simple analgesic like paracetamol, and we prescribe, if there is no contraindication, we prescribe celecoxib here, celecoxib, and oral morphine for PRN analgesia. And yeah, that's the bit that what I can tell from my memory. But we do have a written protocol in the theater. I can share that. Yeah, but yeah, the main difference is no epidural. Rafsan.
Thank you very much. Thank you.
Okay, it seems there is no more questions or comments. Sallu, can you wrap it up, please?
Sir, I have asked one question in the chat box.
Oh, you have? Sorry. In UK, do you use any adjuvant in peripheral nerve block? Must be addressed to Wahid.
No. But in my hospital in North Wales, we do not add any adjuvants in the peripheral nerve block. It's only 0.25% levobupivacaine.
Okay.
Yeah, you got it, Sylvia? Okay.
Mhm.
Yes, but we have seen many studies recently that there are many studies showing that you are using many adjuvants, some sort of noticing that you are using dexmedetomidine. They are publishing their articles.
There may be articles, but in the practicality, like I work in North Wales, so in the wider North Wales, there are 3 hospitals, and there are dedicated hospitals for orthopedic surgery, a separate hospital for orthopedic surgery in North Wales. So none of their protocol, they use any sort of adjuvants in the peripheral regional block. If you're talking about any adjuvants in the spinal, then yeah, diamorphine is there. Widely used is diamorphine. They don't use fentanyl, they use diamorphine. But again, diamorphine not for any day cases or short cases. Diamorphine is usually for like complex abdominal surgeries. They're avoiding any diamorphine or any adjuvant in spinal for any orthopedic cases. So not in peripheral nerve block, there is no adjuvant in the practice that I know of in North Wales. Thank you.
Thank you. Thank you everyone for your nice participation. Thank you, Wais Bhai, for your participation, and thank you, our foreign colleagues. And thank you, Dr. Riaz, for your elaborative presentation. And we are very much pleased to announce and for our conference of Basra on 14th November. Hope you all know about the conference for regional anesthesia in coming days on the 14th November. Hope we will see you again in Basra conference. Thank you. So thank you, sir. So we are concluding the meeting for today. Thank you, everyone.
Thank you, everyone. Thank you.
Thank you.
Thank you.
Thank you, Popak. Thank you very much.
Thank you, sir.
Thank you so much.